All right. Good morning, everyone. Did everyone get some breakfast? Not those on Zoom, of course, but those of you here in person, there's coffee, there's breakfast. Thank you for coming back. Good morning. We are really excited to have you here today. I hope this feels not like too long of a day back in medical school in a lecture hall. We'll try to make it both informative, but parts of this interactive. It's a nice day, so we have a lunch kind of Q&A roundtable thing planned, and we were hoping the weather would be nice enough that our small groups can go outside if they wish. So we'll try to break the day up. We have lunch being delivered a little bit later also. One thing we're going to try to do differently than we did yesterday is try to pass around the mic for Q&A. I think it was hard for some of our folks on Zoom to hear some of the discussion in the room. So we have one mic set up over there. So if you've got questions or discussion, if you could, and this will also keep us all awake throughout this long day, jump up and just shout your question into the mic. We'll also try to pass that around the room on that side. And then I've got this mic that I'll jump up, thank you, and try to pass the mic around this side of the room. Does that sound okay? Other housekeeping stuff, if you are here in the room, please, there are QR codes on the desks all around. Please scan that and just register your attendance for two reasons. That way we can track that you were here and send you the highly coveted certificate of completion for your faculty development. And we can also send you evaluations for the sessions afterwards. We're very eager to get your feedback so that we can, we're going to do this whole thing again in July and then probably every year moving forward. So we really want to hear how it went, how we can improve, what else you need from us. Awesome. We've got some bright faces on Zoom up here too. If you are on Zoom, there will be a link put into the chat so you all can register. Okay. So we'll go ahead and jump in. Are there any questions right off the bat? Any concerns? Is anybody hungry that didn't get breakfast? Feel free to jump up at any time. Okay, thank you all for not sitting in the back. All right, so the first session we've got this morning is kind of LIC 101, teaching feedback. This is a little bit more about our rationale. Yesterday, I spent a lot of time kind of alluding to the evidence, how much we believe in this model. So I'm going to dig in a little bit more into this. Our audience is definitely mixed. So for those of you who've been doing LICs for a while, some of this will be review. So bear with me. Many of the folks in the audience, though, are new to our model and our preceptors. So I'm trying to speak to everyone and also give those of you who are more experienced with this LIC model, some of the language, some of the tools, some of the information that you can use to go out there and recruit and sell this both to our students and our faculty. Ty Loxbizer is here with us today. We're going to share this presentation. She'll be doing the second half talking about some of the high level tools that we can use for feedback. All right, so our learning objectives today, we're going to help you support your LIC learner and enhance your teaching experience through an enhanced understanding of what this LIC model is all about and why we're doing it. We'll help you build a partnership with your student so that they can actually bring value and meaning to your practice. I think one of the more motivating reasons for us to bring this LIC model forward is we really believe this is better for our faculty. We've seen that play out here at CU, and that's definitely been shown in the literature as well. We want to help you develop a plan to approach your first day with your student. I know for many of you, September seems a long ways off, but that'll be here before we know it. So we want to send you off with a game plan for your first day to ensure you get off to a great start to your year together. We'll help you deliver meaningful, effective medical student feedback. And then at the end, we'll give you some important resources for your precepting year together. Hello. All right. So evidence-based education, this was mentioned a couple times yesterday. We really, approach clinical medicine by trying to identify best practices. And when we think about medical education, I think we want to do the same. So when I think about the evidence around medical education, LICs are really where it's at. when you look at educational theory for adults, spaced and interleaved learning with integrated experiences supports retention of information. That's been shown in elementary school as well as adult learning. And this is what an LIC is, right? So the original thinkers sort of about developing this model really went back to the educational theory and thought about these principles and drew this together in designing this model. So we are really putting theory into practice. Building relationships with faculty that can provide meaningful coaching and feedback is the core of this model. Our students, I think, have been wanting this. They always say they don't get feedback, and we're here to provide that. And I think that ends up being one of the most important things that drives their satisfaction with this model. We really can limit the hidden curriculum and provide a supportive learning environment. And I think that's another thing that ends up being super critical to not only their professional identity development, but also their satisfaction with this learning model. Facilitating learners' relationships with patients is one of the core things that helps amplify the development of empathy and patient-centeredness. I talked a little bit about that yesterday, but we'll dig in and try to understand that a little bit more this morning. Creating greater learner satisfaction with their training, I think has been really powerful. We've seen that play out so dramatically here at the University of Colorado. Our students have really been voting with their feet in terms of what they prefer in terms of their clerkships, and the split in our course evaluations has been dramatic. And I think one of the more powerful things that we can start to think about is, especially as our LICs now are placed in individual healthcare systems with unique curricular goals, to take this sort of lofty view of what are the healthcare needs of our society or our communities, and can we shape what our students will become by thinking about how we train them and the role models we expose them to. So in summary, I think the best way to put this together is that LICs clearly bring together best practice education in terms of the evidence. We are able to prioritize our faculty experience with teaching, and then consider at the same time our population health needs as part of our curricular redesign. So digging a little bit further into this evidence, probably the largest body of evidence for LICs starts with the students. So the original studies looking into the value of this type of education started with just looking at the student outcomes. So can these students perform equally well academically? This has been well borne out. These are just a few of the references. There's quite, at this point, a large body of evidence supporting this. Students in LICs perform equally, if not a little bit better, on all the sort of traditional measures of academic performance. So standardized exams, clinical assessments, sub-Is or acting internships, as we call them here, board exams, and then ultimately their residency match. This is a picture of one of our former LIC students proudly holding her residency match letter. We also know that students demonstrate improved measures of patient-centeredness and empathy. That's important in the short term, but I think what's really powerful here is that this endures after graduation and up to 5 years after graduation and probably beyond. This is one of the original studies looking at patient-centeredness and how this persists. So before clerkship, students don't look statistically different. Post-clerkship, there's definitely a split. And this actually continues to widen up to 5 years post-clerkship and maintains that statistically significant difference. So how do we achieve these outcomes? I think there are kind of four, as I've come to think of it, or as Shanta Zimmer refers to it, like, what is this? What is the special sauce here? I think there are kind of four key elements. Perhaps most important for this audience, it's all of you. It's our dedicated faculty that works so hard with their students day in and day out. So I want to highlight what I think it is that makes our faculty relationships with their students so special. It's creating authentic roles for our students. It's moving them from kind of being tourists in the clinical environment and hoping to kind of catch as catch can when they find a great teacher or they find some good learning, to really giving them authentic roles as physicians in training. It's the creation of an LIC student patient panel, and we'll talk about a little bit more about what that means. And then finally, it's our developmentally progressive case-based didactic. So I'll talk a little bit more about what that looks like. So the LIC really allows us to reframe the role of a medical student. In our current block clerkship model, there's some challenges, and I think this has really changed for most of us. When I was a medical student, I had the same attending on most of my clerkships all month, and we hung out at night and got ice cream when things were slow. Like, I was part of the team, and it did feel more authentic. But because of the changes in the clinical environment, because of the changes in the learning environment, things have really changed. There's time pressures, there's duty hours, there are a lot more competing demands that in some ways pit the patient versus the student in their learning. And things are just chronically under-resourced. So I think we are sort of at a breaking point where we need to redefine how we teach students in order to make that successful. Students are sort of forced to become opportunistic, where they're sort of scrounging and looking for places where they can fit in, which has made them sort of passive observers a lot of the time. This isn't exclusively the case. I still teach in the traditional blocks, and I think I work hard to find opportunities for them. So I don't want to harp too much on this. I think there are great opportunities for our students, but I do believe we can do better. I think often there's inadequate supervision, observation, and feedback. So these are areas we're trying to do better, and often limited opportunities for reflection and discussion. So challenging things do happen. And what our preceptors in a longitudinal format are really able to excel at is sitting down with them afterwards. We talked a lot about this yesterday in the bias and upstander training, about how often we can't fix these things that happen, but what we can do is provide an opportunity to discuss and reflect with our students when it does. So thinking about authentic and longitudinal roles with patients, I think what happens pretty quickly with an LIC student is that they become true novice members of the healthcare team. They're able to really share in the responsibility for patient care. So I've been a preceptor now for close to a decade of an LIC student. And I have a new one for this hybrid year who started off with immersion. So she's only been working with me for about a month now, but already she has several patients that she's following that she's essentially their doctor. She's the one calling them. She's the one following up on the results and the consults. I want her to share in the responsibility for patient care. So the patient doesn't show for an appointment. She's the one who knows that and is telling me. And so I'm able to offload some of that responsibility and really expect her to take that on. So what I'm able to do is help her transform from an observer of me taking care of my patient to really becoming the care provider, becoming the advocate, becoming the navigator for that patient. There are lots of roles that she can take on. Because I'm working with her longitudinally, I have all year with her. I see her almost every week. She was on spring break last week, so there are little interruptions here and there, but most of the time she's with me. I can start to trust her. So we talk about the entrustable professional activities. This is what entrustable means. I now trust her. I asked her to follow up on that CT scan, and I start to trust that she will, and she'll let me know. So I don't put it on my to-do list anymore. Students can earn that progressive level of care responsibility. If she fails to do it, then sort of I ratchet down that level of responsibility, and I know I need to step it up. But as she does more and more reliably, I start to trust that more. Through this sort of dynamic relationship with me as her preceptor, she starts to develop this really holistic approach to patient care and sense of responsibility for individual patients. So a few more words about the patient panel. I think this is kind of a foreign concept until you start doing this. So now my student has one patient, but what are the expectations for her over the course of the year? I have a panel, a large panel of patients. Which ones is she going to pick from me in internal medicine? She's also with a pediatrics preceptor, a surgery preceptor, an OB-GYN preceptor, a family medicine preceptor, and so forth. How does she build her panel? So students should serve as the primary points of contact, the advocates, the navigators for their patients throughout the clerkship year by attending their visits, their admissions, their procedures, their deliveries, so forth, for all of these patients. But they can't do that for every patient with every preceptor, right? So how does this actually come together? Students have a minimum number of cohort patients or panel patients in each specialty. They're expected to follow these patients over time in care venues. What our expectations are is that each cohort patient needs to have contact with their student in 3 separate encounters over the course of the year. And we define encounters very, very broadly. So an encounter may be an actual physical visit with their preceptor. It may be an admission. And when we say admission, it's not every single day that you round. The admission is an encounter. It may be a telephone call to be like, hey, your labs don't look great. What we're going to do is I talked to Dr. Adams and we're going to adjust your diabetes medicines. Here's our instructions. Let's kind of talk this through. Do you have questions? Oh, you do have a question. I don't know the answer to that. Let me call you back. I'm going to talk to my preceptor. So some of that can occur virtually or by phone. So we try to be very sort of open-ended on what an encounter means. Sometimes it's a home visit. So think broadly about what these encounters are. What we really want to be is sort of holistic in our idea of what this continuity means for our students. Obviously, they can't follow every patient they see. So I can see 10 to 12 patients in a half day. They may go that whole day and see a bunch of patients with me, and not a single one of those will be in their panel. Part of your job as a preceptor that we'll talk about, there's a whole nother session on this later today, is managing this patient panel. So we'll dig into this a little bit more on how you can support this and how you can help students identify great patients and really support their learning in this way. Just to give you sort of a broad strokes idea, this is a list of their requirements. As you can see, we want them to get a broad view of clinical medicine. So basically, we require 1 to 2 patients in each of our core specialties and a couple patients in kind of broad disease categories, like cancer, like chronic disease, like end of life or palliative care. And then we have 5 patients that students need to pick on their own. So this is kind of where the individualization of their education comes in. So if you have a student who's really interested in OBGYN, these may all be women who are pregnant or with women's health conditions. If you've got a student who's interested in surgery, these all may be surgical cases. But it allows students to kind of follow their passions. What we really are embracing here is the longitudinal learning and the development. Again, this ties back to the empathy and patient-centeredness. It matters less what the patients are and what conditions they have, and more that they're following patients longitudinally. We do want to sort of spread this out, so we can't have a student who's interested in pediatrics who only follows kids. We want this to be spread out a little bit, but we also want to balance that with individualizing their curriculum so they can choose individual patients. And now I want to talk about the value of our faculty. We hear this time and time again from students that it is the faculty that make their experience. So this is a shout out to all of you and words of encouragement about your value. These are a couple of comments from our students from our various LICs that we've collected over the year. At the end of the year, they all fill out course evaluations. These are, from our open-ended questions. How is the LIC as a whole? Any specific comments you want to add that'll help us shape this for future years, things like that. One student writes, one key strength of the LIC is the ability to connect with preceptors over time, which allows them to help identify areas for improvement in learning. It also allows us to help become integrated into the care of teams. We will also be talking later today about the importance of interprofessional teams. I think all of us who are practicing clinicians know the value of our teams in taking care of patients. The LIC really allows us to embrace our students in those team-based care models, and our students identify that and appreciate that. That's also a way for us to share in the teaching of our students. Another student writes, the greatest strength of this program is the dedication of faculty members to our education and the population they serve. I don't know if there's a clearer way to state the importance of your work here. And finally, I'm blown away by how hard all my preceptors work to ensure the immaculate care for all of their patients and how they approach each visit without any sort of judgment, but instead a genuine desire to use whatever resources they can to help their patients. I love this quote because I think this shows us that our students see us and how hard we're working and value our role modeling. You don't have to be perfect every day. I think this is the value of the longitudinal model. I have kind of hard days at clinic too, and the value of the longitudinal model is that they'll see me on good days and they'll see me on some of my harder or bad days. But they'll see me and they see that I'm working hard to take care of my patients. They see you as their role models and they want to emulate that. And then finally, the team-based learning approach. So every week, our students will gather for a half day of didactic or small group learning, roughly every week. And so the purpose of this is sort of multifold. So this is where community is built amongst the learners. This is also where we deliver our didactic curriculum. So there are a number of learning objectives across specialties that we try to weave in and complement their clinical learning and reinforce core concepts. This is by definition in a small group format because our LICs are in small learning communities. We want this to be interactive. This is how adult learners learn best, and they are eager to bring forth what they're learning in their clinical spaces and share that with each other and build on that. So much of this is in a team-based learning format, not all of it, but this is what I'm going to highlight here because I think it complements the LIC learning style so well. What we aim to do with team-based learning is support clinical reasoning. So students have assigned reading or pre-work. Sometimes it's a podcast, often it's an article that will prepare them for the case-based learning that they'll do. Then they take a readiness assessment ahead of time. So Dr. Luxpfizer will be talking to you a lot about assessment and our belief that assessment drives learning. So that allows them to consolidate what they've learned and then apply that to cases. And then they come together and work through cases together. The cases have multiple sections, and those sections weave in our pillars. So there'll be much of it dedicated to clinical learning. Some of it weaves in our health and society pillar. Some of it weaves in basic medical science. So this all comes together to build our didactic curriculum. We also believe this fosters a growth mindset. So this is a safe space with their set peers and with their set faculty where they can stumble. They don't have to know everything. That's not really the point. These cases are meant to be hard and meant to expose areas where they don't know, and they can learn together and teach each other in that safe environment. So I'm going to go over a few of the nuts and bolts. Again, this is the section where if you are immersed in an LIC, you know this stuff. For those preceptors who are new, I hope this provides a little bit of clarity to how this whole complicated logistical LIC comes together. So our LIC is comprised mostly of ambulatory longitudinal integrated experiences. So the longitudinal portion consists of students being matched with specialty preceptors in core specialties. So we have 7 clerkships in our LIC, internal medicine, family medicine, surgery, OB-GYN, psychiatry, emergency medicine, and pediatrics. I do want to give a caveat here that several of our LICs are built in more of what we call a general practice model. So they may have a internal medicine preceptor that encompasses some of their psychiatry learning objectives. They may have a family medicine preceptor that encompasses almost all of these learning objectives. So they don't need to have necessarily a dedicated preceptor in every single specialty, but we will cover core competencies in all of these core disciplines. They also have these cohort patients or their panel patients that I've already talked about. The learning is integrated. It's meant to be patient-centered rather than specialty or team-centered. Learning is spaced and interleaved. It's intentional that they only see their preceptors every week or every other week. That allows them to integrate and make connections between specialties. It's actually not that different that I see abdominal pain in my internal medicine clinic compared to what they might see in abdominal pain in the emergency room compared to what the differential is in pediatrics or an OB-GYN. There are at least connections that can be made there, and that's what the interleading is all about. We also emphasize interprofessional collaboration in patient care. Most students will do inpatient immersions. The goal of these is not to create a traditional block. So I think this is something that I am pushing back against frequently when there are questions asked, like, oh, okay, they'll just do internal medicine. For 2 weeks? Really? Are they going to learn everything they need to know about internal medicine in 2 weeks? The answer is, of course not. They have all year to learn internal medicine or pediatrics or surgery. This is a component of their rotation that lasts all year. So the goal is to expose our students to this inpatient acute care and to allow them to develop skills that ultimately support their longitudinal comprehensive care of patients, and allows them to focus on acutely ill patients, practice admissions and discharges, do oral presentations, notes, and consults that might be different than they are in other settings, to work with inpatient teams, and ultimately to explore careers that might be different than what they see in other settings. Again, I'll emphasize it is not a condensed clerkship that we expect students to achieve all of their learning at the end of. The remaining inpatient exposure comes from their longitudinal patients. So they're following a patient that gets admitted to the hospital. They should go see that patient in the hospital and continue their inpatient learning. I will emphasize again here, this is slightly different for our GP model LICs. Those students may or may not have all of these immersions and may emphasize more of the longitudinal care of those specialties to achieve their inpatient or acute care objectives. So how does this all come together into an actual schedule that makes sense? This is just an example of what this may look like. Students spend a half day with each of their core specialties. They have didactics once a week. They have several blocked out times for independent learning. Emergency or urgent care shifts get factored in here too, either scheduled during the independent learning time or on the weekends or nights. As I've mentioned, inpatient specialty care also gets woven in here often on the inpatient or on the independent learning time. This independent learning time, as I like to tell our students, is not free time. This is when they should be engaged with their panel. This is when they're doing follow-up phone calls, emailing their preceptors with questions, often going to appointments. Sometimes this requires shifting things around. So if they have a follow-up appointment from pediatrics, that the kiddo that they saw with their preceptor has a follow-up appointment in specialty care, but it happens to be on a Thursday morning instead of on a Wednesday when they happen to have independent learning time. They may need to work with their coordinator to shift that surgery time so that they can make that arrangement. So there's a lot. This is sort of the skeleton schedule, but things shift quite a lot. Which brings me to the important role of our coordinators. So I have come to believe that this is probably the most important role in any of our LICs. This is truly the glue that holds our program together. As someone who has been a director of an LIC for 8 years, my coordinator is not here today, so this is not just lip service to her, but she is truly the most essential member of our team. She manages all the student and faculty schedules and figures out where every student is supposed to be every day. And then when things need to shift, she is the one who creates that flexibility around panel patient care. The coordinators are also ones who track and organize student assignments and assessments. And I think perhaps most importantly, the coordinators are really that safe space for students. So when those really great moments happen and they finally get to deliver the baby of the mom they've been following all year, it's often the coordinator's office that they run to and celebrate that with. Also when something hard happens, that's often the shoulder that they're crying on, so to speak, and getting the support they need. So the coordinator's value is truly immense. For all of you who are preceptors out there, please communicate with your coordinators. I'll just make that plea for them. They are managing an immense amount of data and information to build these schedules, and that's really essential to make these programs work. So in my last few minutes before I hand this over to Ty, I'm going to give just some sort of more practical tips on how we can be successful in setting up our students and their work with us for the entirety of the year. So you'll get information again from your coordinator before the LIC begins. Here's your student's name and here's the day they'll be working with you. But at least in my experience, that may be it. So I would suggest sending an email if they don't send you an email, introducing yourself and offering to get to know each other a little bit. Sometimes this looks like a cup of coffee. Sometimes this may just be an exchange of emails, but I think it's really intimidating. These are second-year students who've never been in the clinical space. They're so nervous. And so introducing yourself and creating sort of a safe space so they see you as a human and someone who's excited to welcome them into your clinical environment is really helpful. They also have they're so nervous. They have a million questions like what time should I arrive? Where should I go? Where should I park? What should I bring? What should I wear? Do I need to have a white coat? Just help them out and tell them that ahead of time. It can be helpful to tell them what your typical session or day looks like. So for me, I'm always an hour behind. And so I like to tell them that ahead of time. So when they see me running around like a crazy person, I tell them that so they don't think it's their fault that I'm always so late and stressed out. And I tell them that they should write down all their questions and we'll talk about it at the end of the session. I try to tell them what expectations I have. On the first day, I actually have no expectations. Just follow me. You'll get to see the flow of the clinic. You'll get to see how I interact with my MA. You'll sort of get to see how this crazy flag system works at our clinic so that I can communicate with my MA. Just shadow me. And then later on, we can talk about how many patients I want you to see, how many notes I want you to write, and so forth. I also like to ask what expectations the student has. What goals do you have? What are you hoping to get from me? Is there anything the student should do to prepare? Again, on the first day, I don't really need them to prepare, but as we move forward, I do want them to read about patients ahead of time. And I want to tell them how to contact me. For me, it works way better to have a student text me. I'll get that immediately. You may prefer email, you may have a pager. Let them know how to find you if they get like a flat tire on the way. And then I would, as time goes on, maybe after your first day, think about these things as you move forward to help invest in each day and prepare your student for success. So on the first day, review expectations. You might want to help your students set some goals. We'll have a later session talking about goal setting. Plan for feedback. I think one of the beauties of the LIC is that you can provide that sort of ongoing in the moment feedback, but you may want to have sort of set intervals of time also where you're going to sit down maybe at the end of each semester and give more meaningful or more summative feedback, I should say. You probably want to introduce them to your team. There may be orientation you need to do to your office or hospital. I know I have to give my students this checklist for the Joint Commission that shows them where all the fire extinguishers are and stuff like that. So if you need to get that done, plan for that ahead of time. And then I also think about daily check-ins. So it is, I think, well worth your time to get to your sessions 5 minutes early. This doesn't take a lot of time, but we've heard from students how stressful it is to have a preceptor that doesn't take just a minute to kind of prime the student and get them oriented to the day. So getting there a few minutes early to ask them like, hey, is there anything you want to focus on today? What are your goals today? It doesn't have to be like, what are your goals in life to be a doctor? Like, hey, is there anything you want to focus on today? Here's my schedule. Which patients are you going to see? So that they have a game plan, and while I'm off running around doing a million things, they maybe have something to do. Oh, I could read about this patient, or hey, I don't actually know heart failure as well as I should. I'm just going to quickly review that. It's helpful to tell your students how long they should spend with each patient. So, especially in the beginning of the year, they could disappear for an hour and a half, but if that's not going to work for you, tell them so they have that expectation set out. Priming the learner or focusing your learner, this can be real frustrating for both you and the student if you don't tell them what you need. So if I've got a patient that I can look ahead into the chart and see that they were just in the ER for chest pain, and I'm like, okay, we got to ask a lot of questions about that and see how they're doing. But I don't tell the student that, like there's not mind reading going on here. And then they go in and find out all about, their knee pain and the fact that their daughter just moved out of state and all this other stuff, and come out and they're super proud and give me a great presentation about that. And I'm like, oh my God, you've been in there for an hour and you didn't ask about the chest pain or the ED visit. Like super frustrating for me. And then the student feels terrible because I'm like, okay, great. Never mind. We're not even going to talk about that knee pain. I don't care. Now we have to go in and redo the whole visit. That would have gone a whole lot better if I'd been like, the most important thing for you to get out of this visit is follow up on that chest pain. And then they can be set up for success. So prime your learners. Tell them what you want in terms of written notes and oral presentation. So you may want them to write a note on every patient. You may not, but tell them so they know what to do. If you want them to do your patient care follow-up tasks, tell them before they leave and come up with a plan. If you're someone who likes to have your follow-up done within 24 hours, give them a heads up on that so that when they get into the patient chart and they've done all this research about what to do about that patient's x-ray or labs that came back, and then they call you, it's like not super disappointing when you're like, oh yeah, I already took care of that. So coordinate with your student so you're on the same page. I think it's also helpful at the end of that session to look ahead to next week and be like, oh, these would be great patients. Communicate with your student ahead of time so they can think about what they could prepare for. Similarly with topics, I think this is something we'll talk about again in our LIC Teaching 201 this afternoon. But this is a great opportunity to foster self-directed learning. So, wow, it seemed like you had kind of a knowledge gap, and that's cool because it's early in the year, but you didn't know much about this topic. So I want you to read and prepare and give me a short presentation on X, Y, or Z before we meet next time. And then do provide a little bit of time to debrief and provide feedback. If you're running an hour late like I am, it doesn't have to be in that moment. What I often do will say, like, I'm going to read your notes later and summarize some quick tips that I'll send you by email. I often don't have time to do this at the end of the session. All right, this is my final slide. Other just quick tips for success. This sort of goes back to the panel management. I think one of the most helpful things I've learned over time is that whenever I have a patient admitted to the hospital, it's important to tell my student that. This is coming from sort of the ambulatory perspective. Me sitting around and waiting for one of my patients that the student has seen to be admitted could take all year. But what often happens is that I have patients in the hospital pretty frequently. It just may not be someone that the student has seen before, but it works equally well for me to be like, hey, you've never met this patient. Go meet him. Tell him you're with me. And then the student's thrilled because it's kind of like me by proxy visiting them in the hospital, and then they can see him on the back end with me for continuity after discharge. Help identify good patients to follow. I'm not going to steal thunder from our later presentation on managing panels for your students, but there are great patients for your students. Those that see you frequently, they tend to be nice patients. And those that have sort of complicated disease, when you see one of those patients, be like, hey, this is someone you should see. They'll be likely to be back and they'd be great for you to learn from. I tend to value quality over quantity in terms of my patients. If they spend all day with a single patient, but there's a ton of learning there, that's better than them seeing a ton of like really quick hits in terms of patients. A good example of this is just a couple of weeks ago, I had a patient, my student actually is a good example of the first bullet too, that my student met in the hospital when he went in for a biopsy of a liver mass that was picked up incidentally that turned out to be metastatic gallbladder cancer. So the prognosis is terrible. He came in for sort of his end of life care discussion, and we had a long chat with him, and then it was clear that the next step was to have our social worker come in and explain to him what palliative care was and set up that referral. So she stuck with the social worker and probably had the best learning that she will this entire year with our social worker. I went on and saw a bunch of kind of routine patients, but by far the best thing for her was that quality with that one patient that she spent all morning with. Don't feel bad about having your students use downtime to read, do patient follow-up, review charts. When I'm really busy, that is a better use of their time than watching me run around like a crazy person. I think I can also think out loud. So when I'm, there's a lot of teaching in there from me just like, gosh, here's what I'm thinking. Trying to decide if I should, order this test or if I just need to send them to the hospital. Just talk out loud. I think students take a lot from that. Allow your students to do as much as possible. I think sometimes, especially at the beginning of the year, we don't trust them to try. I think you'll be impressed by how much our students know and how much they can do and how eager they are. Sometimes the menial tasks are exactly what they're eager and ready to try doing. Try to identify one topic that your student can learn more about, send them off to read and learn and teach you. I learn so much from my students this way. and try to directly observe your students doing all aspects of patient care over the course of the year. So don't sit through an entire visit. That would be, especially the beginning of the year, ridiculously time consuming and painful. But over the course of the year, you'll have the opportunity to observe little snippets here and there, watching a history, watching a physical exam, watching them educate their patients. So try to see it all. You have all year with your students, so watch it all, but not all at once. Okay. I'm going to transition. Is there anything in the chat? Okay. Let's go ahead to feedback, and then we'll sort of pause and do questions at the end. Perfect. Okay.
All right. Hi, all. My name is Ty Lockspizer. I am a general pediatrician in the Child Health Clinic, as well as the Assistant Dean for Assessment, Evaluation, and Outcomes. So you get to hear from me a little bit more later today when we talk specifically about assessment. And as you'll hear in that session, one of my biggest interests in assessment is because assessment is connected to feedback. And so in the next couple of minutes, I'm just going to talk briefly about feedback within the LIC setting, and in some ways, the power of feedback. So I tend to think about feedback as one of the most powerful teaching tools that we have. Similarly, I think of assessment as a powerful teaching tool. A lot of people like to think about assessment as just sort of this test and thing that we have to overcome, but spoiler alert, that's not always the case. The challenge is that our medical students frequently report that they don't get enough feedback. And sometimes there's absolutely truth to that. Sometimes they're not getting enough feedback. Sometimes, though, it's we as teachers or educators aren't doing a good enough job making sure that they recognize that some of the talking that we're doing is, in fact, feedback. So I have a pediatrician that I know nationally who decided to do sort of a little experiment about this, very unscientific, but he bought a big bag of Hershey Kisses. So he's on rounds, an inpatient pediatric hospitalist, and he just decided he was going to throw a Hershey's Kiss at any student or resident anytime he gave them feedback. And he said that after a day or two, all of their pockets were full of Hershey's Kisses. Because simple statements like, oh, nice job, getting that history, or what do you think about adding asthma to the differential diagnosis? That's feedback. But people don't always recognize and see that that is feedback. And so some of our job with our LIC students is to call this out and help them get better at seeing that feedback is all around us. So with that in mind, I love this book called Thanks for the Feedback, The Science and Art of Receiving Feedback Well. And one of the author's big arguments is exactly what I just said, that feedback is everywhere. It's just up to us to start paying attention to it and looking for it and making meaning from it. They also argue that there are 3 types of feedback. There's appreciation. I see you and I'm grateful for your work. So this is, after a day with a student, great job today. It was really fun to work with you. That's appreciation. And sometimes I feel like in medicine, we poo-poo that type of feedback. We're like, oh, that's not specific. That's not good feedback. But the reality is that us as humans, we need that sense of connection. We need to feel like we're seen and that we're valued. And so oftentimes I will say that explicitly of, wow, you did a great job today. And just FYI, that's appreciation, not feedback, to sort of help the student recognize that I really am sort of seeing them and giving them that positive affirmation, but I'm going to go on to provide more specific feedback. The second is evaluation, which is sort of about that idea of where am I standing? A lot of our students are worried. They think, oh my gosh, am I going to fail? Am I the worst doctor ever? And so the evaluative sort of feedback is you're doing great. You're right on track. You're where you need to be. Or it's the flip side. You have someone that's struggling. It's your job as a teacher to say that. I'm worried that you might not pass this particular rotation. I'm worried that these skills that you're demonstrating are not where they need to be. That is important for the student as well. And then finally, the form of feedback that we're going to focus most on is coaching, which is the idea of growth. And this is how you can improve. And for me, that is the absolute best part of the LIC. And I've only been in it for 4 months now. But it's why I'm a pediatrician, because I love growth. And it's also why I'm an educator. And so this idea of being able to see my students improve over time and all of a sudden do a visit with a complicated patient all by themselves, I just feel like this proud little mama sort of watching them bloom. And some of that is because I've been committed to helping them grow and to providing with them with that feedback and thinking about next steps. So one of the big things that I highlight is that a lot of times we talk about, giving feedback as if it's something that I'm just going to throw to you and then, walk away. I gave you feedback. And the reality is that I think about it more that our goal is not just to give feedback. If I give my student feedback and they don't do anything with it or change their behavior or improve and grow, what was the point? And so instead, I really think about it that my goal is behavior change. And so in some ways, I start thinking more along the lines of all the motivational interviewing and behavior change that we learned when we were becoming doctors. And that it's really about the conversation and getting the learner's buy-in. This is not the case with some of that quick one-off feedback of, oh, your differential was great, but you didn't include asthma. I do that. I'm not going to go through a whole, motivational interviewing. Let's have a big conversation about why asthma needs to be included in the differential. But if it's bigger feedback or something that's really requires more change or more growth and improvement, then it's really about the conversation. And so really starting with their self-reflection to gain their insight, using their words, their own goals, that can be more helpful at triggering change than you just telling them, you need to start arriving more on time. It's not appropriate that you're late every minute, every day. That's feedback, totally appropriate, not okay for the student to arrive late. But they might hear that and just sort of poo-poo it. She doesn't know what she's talking about. She doesn't know my life. She doesn't know that I was, in there talking with the nurse and it wasn't that I was late. And so if you connect with them, they're more apt to hear what you're going to say. I use this slide to sort of describe our key characteristics of good feedback. I feel like this is drilled into us a lot as educators. Feedback needs to be specific, focused on behaviors, descriptive. So really all of those get at this idea that the student needs to be able to walk out of any conversation and know what they need to change. And it can't be, you just need to be a whole different person. It needs to be something specific that's in their control that they can do differently. In addition, the sort of non-judgmental and focused on improvement is really that idea that, hey, I'm here with you. And the reason I'm giving you this feedback is because I want you to be the best doctor you possibly can. And so it's really about aligning yourself with the student to help them to see that feedback is what helps them grow. And then finally, the last piece is timely, that I forget things. And so timely for me helps me as a preceptor and it helps the student. Because if they can sort of have the feedback in the moment or close in time to it, they can sort of be able to remember the details and think about how they might do it differently next time. I love the word yet, because one of the things that I think is always really interesting, and this is going to get at the idea of assessment, is we ask questions. On all of our evaluations that you filled out about our students, it always says, what are they doing well? How could they improve? And oftentimes, very common answer, and how could they improve, is nothing. Keep doing what you're doing. And the challenge is that I sort of push people and think about, is that really the case? Isn't there something that they need to continue growing towards? It doesn't mean that they're doing anything wrong, but it's thinking about what is the next step for this particular learner. If they're a clinical medical student, clearly there has to be a next step. If there isn't, then why can't they sit for their peds boards tomorrow? And so it's not necessarily thinking about it in the idea of what is wrong, but what is the next step? One of the key things, and we'll talk about this more with assessment, is that we think a lot about the idea of independence. That we are hoping to develop doctors that can practice safe and effective care independently. Independent doesn't mean I don't know when to ask for help, I don't have limits, I don't make mistakes. But it means that for the most part, you do. You ask for help when you need it. You ask for questions, you ask someone to double check, etc. And so if I'm left with a student who I think, oh my gosh, the student is amazing, you'll see a video of one of my students that falls in that category later, then my thought is, okay, I'm going to picture her all by herself on a deserted island. What else does she need to be able to do to provide safe and effective care by herself? And when I think about it that way, then I can sort of think about things of, well, she still hasn't mastered some of the really complex patients in pediatrics or understanding some of the management plans and what we do. That's probably where she should work. And so it's really that idea of seeing this as growth and seeing this as you are part of the student's journey from student to doctor. And that we need that help and that guidance of what is the next step on our path. And feedback is part of the way that helps us find that path. So with all of that in mind, you can look at me and say, Ty, that's great and all. I have a ton of patients. I'm busy. I'm getting paged and I have 50 emails all at the same time. How on earth do I do this? So oftentimes we hear, don't have enough time, don't have enough space. Also, we hear, I don't feel like I have enough contact with them to assess them. Like, oh, I just, worked with them for 1/2 day. How can I provide any feedback? And then we also hear things like, oh gosh, I don't want to do it. It's a hard conversation. I don't want to tell the student that they're struggling. And so some of the things that I think about in order to mitigate this is one, really thinking about scheduling time. And again, some of this is sort of thinking differently between like the little itty bitty feedback in the moment, which for me, I absolutely use. We're running to the room with the patient. And hey, let me tell you, I loved your presentation, but you know what? You completely forgot to include the birth history. And in this patient, it's pretty crucial. And I think, again, that's where I have gotten in the habit of, as we're rushing to the room, I say, let me give you some feedback on your presentation. And I use the word feedback a lot because then it sort of helps the students, their ears pop up and they think, oh, I'm getting feedback. But the reality is that I just sort of want to tell them, you got to include the birth history. And then if there's more detailed feedback, I schedule time. For me in the LIC, the best thing has been thinking about days where either I can come in early and either have lunch or breakfast with my student or stay late. And just sort of have that time where I know I'm going to be late coming home to my kids. That's just the way it is, but I'm going to give the student my undivided attention. If I don't schedule time, I have my nurse coming over here, I'm getting a text, and all sorts of other things are happening. And so it's really important to schedule time. I don't do it all that often, so it's not like it's adding hours to my week every week. The other thing, and Jen alluded to this, is that phone or email or text feedback is okay. It should not be the only type of feedback that you provide. But I, similar to Jen, oftentimes I'm running out of clinic to a meeting. And so I have very much gotten in the habit of telling my students, I'm going to look at your notes tonight or sometimes tomorrow, and I'm going to email you. And I tend to send them an email and I say, Joe, your differential didn't include X, Y, and Z. I think the management plan needed more detail, etc. And I just send them an email with that feedback. And that way, then they get the feedback, but it doesn't have to be it can be on my time when I do it. Other things to think of is that any observation is probably representative. Like oftentimes we think, wow, that student really wasn't able to get a history, but I only saw them with one patient, so maybe it was an off day, I'm not going to say anything. It's better to say something. And it's better to sort of provide that feedback and say, for this patient, I noticed. I'm not saying for all patients or for everything, but for this patient, I noticed that you didn't use open-ended questions and your history was incomplete. So it's really about sort of telling them what you saw, but not generalizing. And again, as Jen sort of said, observations, the best thing to do is just pop in for a few minutes. I do this with my students and sort of tell them, I might just pop in at some point in time, just continue talking or continuing doing your exam. And I find oftentimes after only like 1 minute of being in there, I have something to give them feedback on, whether it be their communication style, some of the questions they asked, how they did the physical exam, what they were explaining to the patient. And so I don't feel that need to watch every history or watch an entire visit from soup to nuts. It's just that short little bit. The last piece of feedback that I always give is the idea of finding a common goal between you and the student or the person receiving feedback. This is particularly important when you're giving feedback sort of that's more negative or constructive, and also when it comes to professionalism issues. So one of my favorite things to sort of say is, I know that your intentions are, to be a good doctor, to be confident. I worry that other people might perceive this as arrogant or might perceive this as you being pushy. And so what I'm doing there, some people push back because they sort of say to me, but Ty, aren't you kind of sugarcoating it? And again, it comes back to this idea, well, my goal is not to just give them the feedback and say, hey, you're arrogant. That needs to change. But instead, it's to help them change their behavior. And so rather than just saying that, it sort of says, hey, I believe in you. I'm by your side. I know your intentions are good. And I'm pointing something out that I think needs to change. And so it helps someone then to not immediately stop and push back and be like, no, what does she know? I'm walking away. And instead say, I'm hearing something from someone who wants to help me and who believes in me, and they have this concern. Isn't that interesting? And so it's really, again, about that idea of trying to think about how you phrase things to prompt change and to having the student actually hear the feedback that you're providing. The final thing that I say, practice, 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 practice. The especially difficult feedback, oh my gosh, every time I do it, I learn something. And so just like with our students, they need to practice, 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 taking histories, doing physical exams. We need to practice, 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 providing feedback and teaching. No, you're fine. So if you are really concerned about a learner and worried that they're not doing well, that's sort of evaluative side of feedback, what should you do? First and foremost, provide feedback. And if you're concerned, it is all the more important to put it in writing because we need to know if there are concerns about the student. And then the first point of contact should be your LIC director or your LIC coordinator to discuss your concerns early rather than waiting. We have a lot that we can do to help students over the course of the year. If you reach out early, it's so much better. And the big thing that I say is don't be afraid to speak up. Because again, think of your role as helping the student grow. That if you're concerned about them, it's better to reach out early. So all the pediatricians, family medicine doctors, early intervention for developmental delay. That's what we do. I don't necessarily know for 100% that this child has speech delay, but I have concerns. We better at least jump in and evaluate them early and figure out. It's the same thing with our students. So reaching out to the LIC director saying, hey, I just, I want to talk more about the student doesn't mean that they're getting them in trouble or that they're not going to get a high grade. it means that you're committed to helping them grow. So earlier is better, more is always better. And so really just trying to see this as you are partnering with the student on their journey from student to doctor. I finally just sort of summarize, and you'll see this again later, this idea that it's okay to speak out, that we want lots of data points. And each assessment is another pixel that helps provide more detail on how a student is doing and what their unique strengths and areas for growth are as a physician. So with that in mind, Jen, do you want to talk? We just sort of had some additional resources for learning about both giving feedback and also thinking about being a teacher as an LIC preceptor.
Yeah, I'll just highlight these.
I don't know if that's working here.
I'll just highlight these really briefly, and we'll talk about a couple of these further on throughout the day. The first is a link to a website that we've developed through focus groups and input from our faculty and students that takes you to a number of tip sheets touching on a huge number of resources pulled from articles, podcasts, other websites, but also PDFs of single sheets that go over teaching tips related to feedback, but all sorts of other things you may find useful. So please take at least a few minutes to dig into that. The second link there is to a 6-minute video that we've spent time building. I don't know, took us maybe 1.5 years, right, Heather, to create. That is just clips of our students and our faculty talking about what it means to teach and learn in an LIC. So I think it's perhaps best to hear about this from the mouths of people who've done this. So that's worth a watch. And then finally, this is just a link to an article. We'll also email this out to all of you. I read this every year and give to my students every year. It goes through 12 tips, as the title implies, for students in longitudinal integrated clerkships. I think it could equally be titled 12 tips for teaching students in longitudinal integrated clerkships. Covers many of the things we've already talked about. So that is definitely worth a read. And for those of you who are going to be teaching as preceptors or directing LICs, it's worth handing to your students as well. All right, why don't we we're just a few minutes after 9, so why don't we just take maybe a couple minutes if there are questions, and then what we'll do is move into our next presentation and then take a little break, maybe at the 10:30 mark, to allow people to use the restroom, get a refresh on coffee. So I'll do the Zoom again. If you wouldn't mind going to the mic, I'll also run around with this so that our people on Zoom can equally participate. So that one comment in the Zoom from Bella makes me wish I had an LIC student. Won't you have one, Bella? Oh.
Can I speak? Is that easier? I wish I trained in an LIC model. It just sounds awesome. That's all.
Oh, gotcha. Okay. Coming your way soon, Bella.
Ty, when you go by email, do you ever receive feedback back? And then is that like adding more time to your feedback given over email when you plan for it? Do you need to plan for more time than just the original email?
Ty, I don't think that came, the mic might not be on. Can you just repeat it?
The question was essentially, when I provide feedback over email, do I ever get feedback back, which then sort of triggers extra time and back and forth? I think some of it depends on the student, but mostly I tend to find that they reply back and say thank you, or if they want to know more, we talk about it at the next clinic session. And so it hasn't been the type of thing that it's been like then, the email back and forth forever. So.
Oh,
So if there's a problem with a student, can a preceptor maybe contact their specialty liaison instead? They may or may not know their director.
Absolutely. So what I would say is if you have any level of concern, as I would just reiterate what Ty said, there's no level of concern that is too small. if the worst thing that can happen is we convene about it and say, actually, I think we can go ahead and continue to watch this student. The most important thing is that you talk to someone. So I think going to a specialty liaison, going to an LIC director, coming to me, going to Ty, doesn't matter, talk to someone. But a liaison is great too. No.
I'll repeat it. How about that?
How often do you think I'm the one feedback? Maximum time to go between evaluations or
Great. So the question was sort of what is the right timing for sort of that more sit down, more formal, summative feedback conversations, not just sort of the, oh, add this to your differential or your note was too brief. Jen, I actually would love to hear your answer first, since you have done this for years and years, more than I have, and then I'll give you mine as well.
So I'll just tell you what my practice is. I don't know that I have the right answer here, but the time that I sit down to do a more formal, like sit down feedback with my session is every time I need to write an assessment. So the way that'll pace out in the LIC for Trek is we'll ask our preceptors to do that 3 times a year, twice a year. Twice a year? Twice a year.
Yeah.
Okay. So I might actually do it maybe one time in the middle too. But certainly every time I have to write an assessment. So that's when I'm sort of putting my thoughts together. So it seems like a natural time. And my practice has actually been to show them what I'm writing. I'm not going to write down something that I don't feel comfortable telling them about, because they'll see it eventually anyway. So I usually write it out, print it out, and then sort of walk them through what I had written. So that's been my practice.
Yeah, I think that, using sort of our triggers when we send you assessments as a time to sit down with your students, I think is a really great thing. I will also say in my N of 2 that sort of a month or so in or 6 weeks in, depending on sort of how much you've been working together, feels like a good time. Just because for me, that was sort of a time to really help get them sort of making sure that they're integrated well into my clinic and have a good understanding of what the expectations are. And so I found like there was a lot less feedback that I was necessarily providing at that point, but it just sort of helped to have that good check-in early on to make sure that we were on the same page and that, they felt like they understood where things were going and what they needed to do to be successful. And Jen's comment about, printing out what you wrote in an assessment and using that as the fodder for a feedback conversation is awesome. And that we've actually had students that have said that that's the most effective conversation or effective assessment that they've had, because then it's sort of nothing is a surprise and they have it all right there.